So, let's go ahead and call the meeting to order. The reason I'm sitting here doing this meeting is Jim decided he wanted to stay in the hospital last night. So he's fine. It's just that this is a medical term. His vitals are whacked. So they wanted to keep him. So, but he's fine. And from what I understand, fell. I don't know how high the ladder was or what. So that's why you have me here. So, so the first order is any public comment. Seeing none, we'll move on. So we have the approval of the June 26th meeting minutes. So I need a motion to accept. Who's accepted the first? And Eric, you were second. Okay. Jerry, you're coming. Hang on a second. Let's get here. Although, any questions, comments on the minutes? All those in favor signify by saying aye. Aye. Anybody opposed? Okay. Also, in your board package, you had the consent agenda. Are there, I need a motion to accept the consent agenda. Second. All those in favor? Say aye. Perfect. With that, what day? You are up.
All right. Good morning. I once again am asking you, unfortunately, for a brief moment of silence for one of our very best colleagues. Last week, Jace Dykeman passed away after complications from a stroke. He was the director of our RISE program and community health outreach for HIV services. And he truly made those programs a safe haven for those in need, particularly those who were most beaten and most broken. He gave a ton of people in this community hope and saved many, many lives. I cannot tell you how many patients, clients have told me that they would not be alive today or in recovery today if it weren't for Jason's intervention. And so his loss will take a long time for us to fill. And ask that you take a minute to remember Jason's work and his spirit so that we can carry on his work for our community. Thank you. I've posted in the CEO update a couple longer statements this month. Some of it due to the fact that we took a summer break last month. And I wanted to keep you all updated on impacts of the OBUBA HR1, One Big Beautiful Bill Act, and its impacts on us here at RiverStone Health. While we don't expect to see the large decreases in funding that we saw during the original Medicaid redetermination, we did plan in some contingency for losses due to pending legislation. This bill, along with the Inflation Reduction Act, some legislative discussions around the 340B program and others, have all been planned for in the best way possible in this year's budget. While this bill may carry a wonderful title, it potentially takes away over $1 trillion from the Medicaid program across the country and over $186 billion from the SNAP program over the next 10 years. And that could lead to about 51,000 preventable deaths per year. They also calculated, the University of Pennsylvania and Yale calculated that with cuts to SNAP, could see another potential 93,000 early deaths across the country over the next decade. And so we are working directly with DPHHS, the state of Montana, National Association of Community Health Centers, American Public Health Association, and other partners to determine the best way forward best way to make additional plans to help cover folks that may lose coverage. Our biggest worry with the passage of HR1 is a dramatic increase in the number of uninsured patients we will have to serve across the state in the region. And at a time when the cost of living is increasing, this bill adds additional red tape and paperwork for us and other healthcare providers that is just going to decrease access to care. And so we will be working diligently to increase access and try to continue doing what we do best. We're working closely again, like I said, with DPHHS, also with other partners. One big piece of this bill is the Rural Health Transformation Fund allocation out to states. We, through the Montana Family Medicine Residency Program and our Alliance Coalition, worked closely with Billings Clinic on an application to DPHHS for a vision that we all share to increase access to rural health care across the state. Other applications were put in independently by Intermountain Health, as well as collaboratively with the Montana Primary Care Association and the Montana Hospital Association, among others. And so I think our healthcare community will be well positioned to take advantage of funds within that Rural Health Transformation Fund opportunity. Additionally, we celebrated National Health Center Week earlier this month. We celebrated 60 years of progress, and it was a national moment to celebrate 60 years of the community health center movement. We continued to celebrate 41 years of being Montana's very first community health center, and 50 years officially as the Yellowstone City County Health Department. So 51 years this year. We had food trucks each day, some ice cream breaks built in for staff, and then we had one of our most successful healthcare for the homeless breakfasts, definitely since I've been here, and a community health fair in South Park on August 6th. We just continue to thank then our partners on Partner Appreciation Day on August 8th, who just helped make our work as coalitions and partners better for a healthier community. We were able to celebrate that and then share some additional celebrations. Dr. Littlefield and I went to the NAC conference last week in Chicago, and we had one great party celebrating 60 years of community health centers. And we learned some things too. Across the country, only 100 health centers, less than 7%, are combined with a public health entity. And only one other across the country has the unique role of also providing home health. So we can truly say that RiverStone Health is a unicorn. We are officially, definitely by the end of this calendar year, the last remaining public model health center in the state of Montana. And that is something that we are proud of. Giving you some notes on how we continue to roll out our strategy across the organization to become an employer, provider, and partner of choice. And I'll also be sharing a strategic one-pager we have in development that we'll be sharing with all staff so that everybody knows where we're going, what we're doing, and how we're going to get there. The CDC, if it still exists in another few weeks, will be coming to Montana to complete the National Health and Nutrition Exam Survey, or NHANES. NHANES is coming to Yellowstone County independently of us. This is just a heads up that they will be coming. They will be putting their mobile exam center, a few vehicles, in the Residence Inn parking lot from August 23rd to the 26th. So sorry, they were here. And nobody knew it. But I don't know why they chose the Residence Inn. It's difficult to get to. We tried to talk them into some other places, but they were here for their survey. And they were focused on the western part of Yellowstone County. It's with some zip codes north and south of Laurel.
How were the people determined the exam?
They have a whole methodology that they go out and do, and they reach out, and they were doing some door-to-door asks and different things. So they were here and gone. Nicole Gilbert participated in a panel at the Jeremy Bullock State Schools Summit that's been Steel a few weeks ago. And she was a part of a panel that was discussing how school-based health centers in our work in the schools contributes to a safer school environment and improved behavioral outcomes for students. Back on education, I said that Dr. Littlefield and I attended the NAC Community Health Institute in Chicago. We also had the opportunity to meet with Jim McCrae and Tanya Bowers from HRSA, as well as HRSA Administrator Tom Engels, to discuss the administration's priorities for community health centers and the MAHA movement. And Administrator Engels reported that community health centers are the secret sauce to making America healthy again. So we'll continue to hold their feet to the fire to make sure that we receive level funding in the next budget ask. We were also highlighted by the National Rural Health Association recently in our Eastern Montana Area Health Education Center, or AHEC, Med Start Camp. And the story is available there in a link in the email. But Nicole Bacco and the AHEC team were able to host some students and connect them to health careers, particularly some students that are from low income and first generation families that are going to go to school and try to make a difference. And more media, we had a highlight in the media locally from our dental resident. We have the only dental residency program in the state, and our Advanced Education in General Dentistry, or AEGD program, is partnership with NYU Langone. And we matched a resident this year outside of the dental residency match program. And so Dr. Simo Miranda began seeing patients last month and wants to continue to make a difference in oral health. So we're happy to have him on board. Yes, sir.
Who educates you?
So our dentists, our preceptors, Dr. Berlanik is the key preceptor there.
And they have lectures with Langone. They have like centralized lectures that they attend. So some of it's based there.
We also had our annual community baby shower, the Family Tree Nurturing Center and Early Head Start. We celebrated the National Farmers Market Week at the beginning of August with our Health by Design Coalition and the national and our our farmers market down in South Park every Thursday from 4 to 6. We celebrate National Breastfeeding Month in August. And if you didn't know, breastfed infants are at lower risk of certain infections, sudden infant death, diabetes, asthma, and even childhood leukemia. And mothers are at less risk for chronic diseases, including diabetes, cardiovascular disease, and breast and ovarian cancer. So we'll continue to share the message that breast is best. And my midwife wife would be happy that I remember that. Earlier this week, we also submitted the proposal to DPHHS with rural transformation funds. So just wanted to provide you with an update there. At the time I was writing this report, we were trying to keep things under wraps so that we could share our plan and our vision for transforming rural health. There are multiple different plans out there. So we'll see which ones rise to the top once the HHS reviews them. And then final update, we'll have to have her come to a board meeting, Eric. But Megan Gibson is continuing to make rounds with community leaders as our new behavioral health systems improvement specialist. So we'll be coming to the county commissioner soon to provide an update on all things behavioral health systems improvement and moving forward with a new and improved Substance Abuse Connect Coalition and Executive Committee. But we're happy to have her on board. Been having some great meetings with police, fire, other agencies, and community partners, and developing a plan for how we're going to move things forward. And then finally, in protection, I joked last week that Mark and I are vying for the most quotes in the Billings Gazette this month. But you probably saw that we have signed a letter of intent with the family of the deceased landlord for the colonial apartment buildings. And we'll be working diligently to acquire them, while also making sure that those who currently reside there have a place to go should they be eligible. So we'll be working with those residents and folks who are there to make sure that we can get them housed or get them into recovery or other resources program. And then we'll be moving forward with plans to redevelop that corner of the bar.
Any idea on the price at all at this point?
We do, yes, and I'll share that with the executive committee for sure.
Do you know how many more people, legal people, are still in there?
We don't. That's one of the challenges, is trying to figure out who's actually there. And
You haven't gone a week in building it.
I have not. Every time I drive by there, I should just hop in and say hi. But yeah, I haven't yet.
And the new landlord.
Yeah. So we'll see, but more to come there.
So, one other question.
Yeah.
Colonial, but there are also two, I don't know if you want to call them houses or
Connected.
yeah, that's all part, so it's all part of that. So
Yes.
that portion of the block could be enhanced.
Correct. So that's the goal. We want to provide something on that corner that is, instead of a symbol of, crime and human trafficking and poor housing and a lack of housing standards in this community, something that is a symbol of resilience and well-being, and something that provides resources to those who need it. Okay. August was also the perfect time to send thanks and encouragement to our entire environmental health team. So August is our unofficial Hug a Sanitarian month due to the Montana Fair and other things that are going on across the community. They are busy. They are running like crazy to make sure that all the vendors who come into the fairgrounds are appropriate and safe and taken care of and licensed. And also, as part of their work and public health team's work, we are going to begin initiating, I'm glad they used the name I suggested, it's great, a new Clean Plate Club pilot, and announce to the public, as instead of just licensing establishments and providing them with scores and remediation points when we go into and do an inspection, we'll have a now public-facing signage that's either red or yellow, and is a pilot from our public health service designed to recognize restaurants that prioritize food safety. And we'll be making our inspection reports that more easily accessible to folks. So we're going to try this out of respect for transparency and make it more accessible to customers. And this was all developed in collaboration with restaurateurs and industry leaders. So we have the buy-in of those folks that are out there doing the work and owning businesses. And we're going to try this to make our inspection information more transparent.
Certainly a website that people, the public can go to.
There is, yes.
Our website.
Yep.
So will they, I was just looking at, will they make sure that they highlight that in there so people can go there?
So if you scan that QR code,
Right.
it'll take you right there, or go to riverstonehealth.org /restaurants. It'll be right there. Yep.
Yeah. Then you look the restaurant you're looking.
Put in the restaurant. Yep. So we're going to work on figuring out the best way to provide direct access or easy access. And then our public health update for measles, due to the terrorist attack at the CDC earlier this month, data has been suspended. Folks have been working remotely and not back in the doors. And I think due to having the director forced out last night, along with 3 other senior leaders at the CDC, data is going to be particularly interesting and hard to come by the next few weeks and months. Public health is under attack. There is no other way that I can say it. And that is not a political statement. That is factual. That is based on everything that we are seeing, based on our leadership and decisions being made by the very lead public health agency, if not in the world, particularly in this country. And so our team is struggling with that. And I don't want there to be any qualms about it, that this is impacting our work, and it will continue to impact our work. And so we will do the best possible reporting, the best possible work, and we will continue to meet the needs here on the ground in Montana, and try not to let all of the bureaucracy and red tape distract us. We still have work to do. We still have data to report. But even the food systems that I just talked about, the national reporting database for foodborne illness is being changed. And the number of reportable diseases is being eliminated, for lack of a better term. And so our food safety networks, our vaccine safety networks, our data systems are being disrupted. And we will continue to do the work. We will continue to meet the needs locally. But it is incredibly disruptive to the work that we do in public health here every single day.
So you still do the reporting, right? You'll still do the reporting as you have in the past, I'm assuming. So what happens is, from the national side of it, you're not getting any feedback. Is that what makes it difficult? I mean, the fact you don't have any information of whether or not it's going up or down. Explain that to me.
We're not getting good data. We're not getting good, timely data from our data sources nationally. And they have turned off many of the reporting systems that we do use to say, hey, we have X outbreak or we have X disease. And so there's zero bilateral communication in some places now between local and state public health and our federal entities.
It's still there, but the CDC weekly report, which many of us would read every week about what was going on, outbreaks, investigations, and all that. And that sort of information, an entity such as this, And I think I don't think that's being published right now, is it?
There was a delay. I know they turned it back on, but I don't know where it is right now.
Yeah, but the data is initial cost was as good as it was, and it was really an important publication.
So is that data broken down nationally and then by state? I would assume.
Oh, they would do, investigate, like say if there was an outbreak over, 2 blocks from here, they'd send a team and it was really a good sense of what was going on and how and why.
Yeah, I mean, it's hard to understate how much we have historically relied on the CDC, not just for data, but for lab stuff that they verify. They have lab capacities that local labs, state labs don't have. Those communication channels are all breaking down. Immunization recommendations. I mean, for the first time in my career of 20 plus years in public health, we're starting to see professional organizations break away from the recommendations that are coming out from the federal government on vaccines. What's happening right now is unprecedented in my 20 plus years in public health.
Anything else?
That's it. Any other questions, comments?
I don't know, you, Spencer, went through, in talking with the economic impact in the very, very beginning. Is there sort of a wild ass guess as to what the impact will have to us? I mean, I guess there's a range. You could go from very ugly. I mean, if you look at the budget, I could describe that as not good to where we're ending this year. And so is there sort of gut level feel for what this is for this coming year? And I understand you don't know everything, but it's just sort of a gut level feel.
It's not going to be better this year. Yeah. Maybe that's the right answer. Shannon can probably speak to that as it's incorporated into the budget.
We tried to incorporate everything we could into this budget, and then we were conservative again, like we were this with last fiscal year with expenses, just to try to protect against some of that uncertainty. But your guess is as good as mine. That's not a great answer.
Right now, it's a guessing game. Some certainties we know, some federal contracts that are passed through the state to the county or to us directly are drying up or being cut dramatically or completely. And so there's some funds that were coming that are no longer coming for certain things. And then there's other funding that right now, until we have a continuing resolution or a full, passage, there are a lot of unknowns in where federal funding is going to end up. There's a lot of conversations across each department right now of this program's going to be cut completely, or this program's going to receive a drastic cut in funding, but the rubber hasn't met the road yet. So right now it's a lot of trying to plan for what's being said in Washington and then figuring out who's going to keep the lights on. Is that going to turn to private entities, philanthropic funding, other things? Or are we going to be able to fund other programs for patient services revenue in the clinic to keep other things turned on? So right now, it's also really interesting being in a there's no other way to say it. We're kind of isolated in a red state. And, we passed Medicaid expansion in the state legislature. We will see work requirements at some point. Right now, it's unclear towards the end of, by the end of September, the state will have applied for a new 1115 waiver through HHS or CS, to implement work requirements per the HELP Act, which we have been proponents of, we've supported, we've said this is the way we get Medicaid expansion passed in Montana. And we will work with our patients' plans to make sure they maintain their coverage and meet the goals. Over 93% of Montanans already meet those benchmarks. And so the majority of folks will maintain their coverage. We are not anticipating, from a Medicaid funding perspective, what we saw last year and a half ago, the just large drop where everybody had to be redetermined at once. What we will see more likely, and we've talked to the director's office and DPHHS about this, is a cyclical, hey, when you are due to redetermine, you will redetermine. And so we'll work with those patients and try to identify them proactively. The department and us, I think we all learned lessons from redetermination, and we're going to do it better this go round. That's the goal, at least. There is a new public assistance portal coming out, and I'm going to go right into my public policy update, I guess. And the new public assistance portal will help us to help our patients. We'll be able to see them in person. We'll be able to see their applications directly in real time, and we'll be able to upload documents and help maintain their eligibility or offer them another product if they're ineligible. So there's a lot of things being put in place that will help us avoid the pitfall we fell into last time.
Other questions?
Do you have a sense, excuse me, of how many like federal grants that you guys are working with that could be impacted by the new executive order that says that grants can now be canceled for convenience at any time?
We're in full compliance with the original slew of executive orders. And so we did that to make sure that we're not at the whim. But there are our agency partners in conversations that I had last week with some of my friends in HRSA. An executive order is a show off press release, and going to let it be that and not worry about it.
Other questions, comments? Thank you for the update. Megan, I think you were up.
Yeah, so I have just a verbal report. I was with John at NAC and then went straight to moving my 2 children into college. And so my week last week was kind of dedicated towards family time. So, and I've been on catch up the last couple of days. So I think John covered a lot of what I would have covered just from a teaching health center standpoint, from the residency standpoint. We have our new group of residents. They've launched. They are started in all of their rotations and seem to be doing pretty well. That's always an exciting time of year. We had applied for, we had put together an addiction medicine fellowship that Dr. Mulvihill was going to lead, and we had applied for funding to get that funded. That was not funded. And so now we're having conversations about, are there alternative ways, or do we want to are one of the hospitals willing to partner with us to be able to start that type of fellowship in our community, which really is desperately needed. From a recruitment standpoint, we have 4 new physicians that are starting, which is very exciting. We're still understaffed from a physician assistant standpoint. We are going to be trying to recruit a couple more physician or APPs, nurse practitioners or physician assistants. The biggest challenge that we're having from a staffing perspective is we're understaffed with our support staff, particularly our medical assistants and our nursing staff. And that's really limiting the number of providers that we can have in clinic at one time because we don't have the support staff to do that. So we are looking at, fortunately, we have really launched our telehealth in a different way. We were doing telehealth previously, but we changed the platform that we're using that actually makes it easier to do telehealth right out of our electronic medical record. And that's going really well. So this is sort of an opportunity for us to try and expand that service line, since we don't have staff to see patients in person in clinic, to try and build out that telephone or the televisit access. We'll see how that, we'll see how that goes. I think that there's lots of opportunity there. We just need to, really try and build that demand and help our patients to understand that there are some things that you can get care for really well via telehealth. I think nationally, there has been this trend to move more towards telehealth in lots of areas. And I can tell you that I think that's going to backfire. I think that there are I think that seeing patients in person is really valuable. And I do not think that telehealth is will solve, all of these access crises that we're sort of seeing, particularly in rural, in rural areas. But I think I'm glad that we are now using a platform that's going to make it easier for us to see people who are appropriate to be seen that way. We are the school-based health centers. We are expanding with our mobile clinic. We really are expanding access to our schools and to our rural schools. In the school-based health center program. That's been really exciting. Our team has been out and about at all of the open houses across the area, bringing the mobile unit when we can, letting people come on board and see what that looks like. That team is really energized and excited. The mobile unit is amazing. And now we have our garage is built and we have a place to keep it, which is very exciting because that means that our team doesn't have to drive out to go get it and bring it to campus every day. So that's been pretty exciting. Big focus at NAC was really on population health and value-based care. I think as we look at different ways of maintaining revenue stream, that's going to be an area that we really need to focus on and maximize our revenue generation. And population health is a important part of keeping our community healthy rather than just the people who are coming in and seeing us every day. So we actually have an upcoming meeting to really look at how we can improve doing that at our organization. And so I think we're going to do some revisioning of that work and figure out how to improve it. So when we have that plan, I'll share some of those thoughts. I'll share some of those ideas with you. And along those lines of optimizing revenue, we had the NCCA and I guess sponsored is the right, brought a regional expert in coding to come do an audit of our coding practices and gave us some really good recommendations of places that we can, so one way to increase your revenue in my line of work is to see more patients, right? And increase your number of encounters. The other way is to make sure that you're capturing all the revenue that you can from the patients that you're seeing. And I think that we have opportunities there that we are going to, put a plan in place that's really focused on educating providers so that we are coding to the highest level and capturing as much revenue. Some of that involves working with our EMR and trying to make sure that that's making it easy for us to choose those codes. And then also looking at being better on top of our value-based contracts and where do we need to really focus to maximize that revenue. So I think that will be a big project for this year. We already covered the public health issues, and I think that's pretty much, those are the big highlights that I have. For sure.
Megan, we talked about understaffed and PAs and that. Approximately how many people?
How many
people
are we understaffed?
Yeah.
Well, right now, in the main clinic, we are short. We have 4 open MA positions, but
Including the 3 we just onboarded?
No, so 3 we just hired, so they are in training. So essentially it's 7 MAs that we are short. And that really is one of the things that we did learn when we went to some of the sessions at NAC was we really function on sort of skeletal support for our providers compared to some of the other well-functioning CHCs. And so that's already, it's sort of more skeleton support. And now we're missing, some critical support staff. And RN positions down 2. Is it 2 that we're short? 2, 3, 2 from the clinic. I mean, home care we're down
Yeah.
a number as well.
We have 2 or 3. The clinic, we have 2.
2. Yeah. And 1 is fairly new. Part of the challenge and part of what I think we are learning from the RIF that those cuts that we made was that we did not necessarily take into account just turnover and how long it takes. So we have 3 of those MA positions filled, but those MAs who have just joined our practice in the weeks, they are not going to be functional to be able to keep up with a provider for at least another 3 to 6 months. And so that onboarding takes a long time. And so even though those positions are filled and we're paying them, they are not functional to support our providers because of the amount of training that we have to do. And so I think we have to rethink about our workforce pipeline and how we manage that. Does that mean we overstaff for those positions, recognizing that we're always going to have people in training? Do we need to look more aggressively at training programs so that we have, like we've sort of talked about with the APP residency, where we just build into our processes a training program so that we always have people who are kind of ready to go out of the gate and into open positions. I think there are some different ways to look at that, and we do need to figure out that, that issue, because paying providers and not having them available to see patients, we know is not a winning formulation. So,
It's not how to stay in business long term.
no, but we've got some plans, and I think that we're working at it from different angles.
Good, thank you. Other questions, Meg?
Forgot one update. Our last Friday, I had the pleasure of golfing with Steve and a couple members of our RiverStone Health team at Cushing Terrell Classic. And this year, why we went golfing on a Friday was because we were the beneficiaries. Cushing is benefiting our Kid Connect services this year. And so Childhood Advocacy Center, Pediatrics, Nurse Family Partnership, Parents as Teachers, those beneficial home visiting programs that we offer public health, along with some of our clinical services, that Kid Connect bucket was a beneficiary of this year's tournament. And they expect to provide us with a check for somewhere between $20,000 and $30,000 as a result of that effort. So I appreciate Cushing Terrell for their support.
Also, did you tell them what place we came in?
And we came in second. We lost first place by 0.6.
So we were close.
We were close. But it's never good practice to win
Your own tournament.
Yeah.
Yeah.
Speak for yourself.
Yeah.
The public health, Brent?
I have to defer to John because I was not there.
Thank you for deferring. Which John? John Dorr was there. I'll pull up.
Yeah, but I lost my note. You already checked it.
I can call the order at 4 p.m. You want me to go?
Let me pull up the.
page 47.
Thank you. I'm just gonna steal yours. So we had a measles update and we talked about the individuals who were here in Yellowstone County. We had 2 cases within the same household. It's interesting that while we didn't have any additional data to report on additional cases, it was very highly likely that there were additional cases within the same family. However, after the second case, after we did what we are mandated to do and publicly report that second case, the family called us and refused to report any additional cases. They did not wish to relive the public shame that they've had to endure on social media and within their private communities every time that they reported a case to us. And so unfortunately, they learned that choices have consequences. And in this case, choice not to vaccinate the children ends up in public reporting. That is the process. And so we have to keep the public informed when there are exposures and cases. And we did our due diligence. I think we would have done some things differently and will in the future so that we maintain that line of communication. But I think a lesson learned for everybody involved. Environmental health wise, we have been making progress with regulation of kratom. Particularly good news out of Washington is that HHS has recommended through the FDA that they classify certain synthetic variants of kratom as scheduled drugs, which would limit their sale. And so all of that synthetic garbage that is at the front desk at the corner store would be removed and added to the drug schedule. Our new enforcement process is set to go into or has gone into place. And so stores that are food establishments that we help license and regulate have 30 days to remove any kratom materials from their businesses. And we have support from the county attorney's office, from the city attorney's office to help with that enforcement so that we can get a handle on this harmful substance.
How do you check? So will that just be when they're going in and doing an inspection at the store? So that's when they'll look at it?
Right. So we have also notified businesses, food establishments primarily, that the health department and the city will no longer be approving variances for mobile kiosk type establishments. So the coffee kiosks, other things like that, if they are not truly mobile. We've had a number of variances issued over the past few years for mobile kiosks. And it is creating a regulatory nightmare and a safety issue for our community when our folks are going out there and inspecting those establishments. And so we've given everybody notice that if you truly have a mobile kiosk in a mobile facility, we can treat it as a mobile facility. But there were several variances issued for those immobile kiosks that said they were mobile, but you couldn't just hook up a vehicle and move it. It didn't have wheels. It was a fixed shed to a slab.
So maybe a simple way to solve that is if you license them like that, you have an inspection day, say here in your parking lot, and if you want your mobile kiosk
Bring it to
inspected,
us.
bring it to us. And if you don't bring it to us,
It's not mobile.
it's not mobile. You're not gonna get it there. I mean, that's a simple.
I like that, yeah,
Well, that's what I do.
yeah,
Pretty straightforward.
yeah, yeah, absolutely. Absolutely. So we'll keep working through that, but I like that idea.
Well, that answers the question.
Question, is it mobile or is it not? Yeah, yeah. Oh, goodness.
How many of those do you see?
It's,
Mobile and mobile,
there are more than you would expect.
I would imagine.
Yeah, there are more than you expect.
Most of them on slabs.
Yeah. Yeah, so,
So do they, sorry,
Yeah, yeah.
so they would have to apply for a retail food license? Is that basically, they would have to meet the needs and wants of that, right? Or
if
is that-
they're in mobile, they have to meet the standard of brick and mortar. However, if they are mobile and truly mobile, we will license them as a mobile.
Right, I understand that.
But there are certain, the main two requirements that we have been granting variances for are hard hookups to sewer and water.
Right.
For sanitation.
So what are the differences between registering as a mobile or a non-mobile unit? Cost different and what's different about this?
Eric?
So the costs, as far as I'm aware, are not different. The difference is, so so they're both retail food licenses. When you are doing a bricks and mortar food license, you're expected to have all the facilities to ensure sanitation on premise, right? And that includes running water and sewer systems and bathrooms and all those kinds of things. When you're licensed as a mobile restaurant, you have to ensure that you're able to get that unit to the facilities that can provide those sanitation services that can't be housed on it because of the fact that it's mobile. So you have to be able to get it to a facility where you can dump the dirty water and refill the tanks with the clean water. And obviously there's no bathrooms on them, right? So you have to show us a plan of how you plan to have restrooms available for the staff who are working on it. Outside of that, I think they're pretty similar, other than that the mobile restaurants tend to have more limited menus, so less complexity in their menus, and the requirements that need to be met by restaurants are based on the complexity of the menus, if that kind of makes sense. So when a restaurant opens, they show us their menu and we say, based on what you're going to sell, these are the things that you need to do to ensure food safety for the things on your menu. So a coffee shop that's going to serve wrapped up bagels and, pre-made stuff has a lot different set of requirements to meet than a place that's making burgers and fries and, whatever else they make, salads.
Are the non-mobile units grandfathered in or when they?
Yeah, so what we did, our notification to them was that they are grandfathered in until they either try and move it or sell it. So the current businesses, as long as they don't make any changes to their business plan, don't have to make any changes, but we're not approving those variances moving forward is what the communication was.
So that was mobile kiosks. I talked about inspection transparency, and you have a couple of drafts of the Clean Plate Club signs that were in the packet and that project. And so the last update as far as policy committee was concerned is that we received our Montana is doing a 21st century public health initiative. We're looking at public health departments across the state, our decentralized structure of public health, and some key gaps that could exist across the state. And so they completed for every health department foundational public health assessment. And that's included in the packet for you to take a look at. But overall, I would say we're among the best of the best when it comes to meeting needs and having resources here in Yellowstone County. And as one of the largest, as the largest county in the state, I think a lot of our success is due to the fact that we do have the resources, we have the ability, we have the knowledge and the skills, and the commitment of the board and our commissioners and others to make public health a priority and to make sure that we're meeting the needs of the public. So we tend to be not just the leader, but one that other health departments across the state turn to, particularly those in our rural and frontier communities, for requests for assistance, for policy guidance, for other best practices, and we're happy to always, provide that to those communities. And so we'll continue to be a leader. We always thought very highly of ourselves, but this report also confirmed that we are doing what we need to be doing and supporting others across the state.
Motion to accept the public health policy committee.
So move.
Second. You said, who was the second? All those in favor signify by saying aye. Anybody opposed? Okay. Financials. There are a lot of them.
So we are, for those of you that are following electronically, back to page 21. This is where the financial package began, and we are providing to you this time quite a bit of financial information. It includes, I think in this list includes both the May financial statements, because we did not hold a meeting last month, as well as the June 2025 draft or preliminary financial statements. This is our fiscal year end, so these are considered to be kind of work in progress until the auditors have their say, and after they've concluded their review, they'll become finalized. But we don't expect any material changes to these documents. I think we'll start this time maybe approach it a little differently, because we have a document in here that Shanna and Tyler put together that's pretty fantastic. But just hitting on some of the highlights that are included in the finance committee meeting minute. Cash totaled approximately 15.1 million at the end of the fiscal year. That's an increase of 7.1 million previous fiscal year, and so that's a remarkable achievement. It's a good metric. Of that, 12.4 million is unrestricted, and that increased our total days cash on hand almost to 74 days. So that's up from 41 days at the end of the last fiscal year. So
It's an increase of 41 days or from 40?
An increase of 41. Okay, so that was what we set out to do at the start of the year, but with all of our, with all the work and effort that we did in cutting costs, and so we proud to say that we achieved that what we set out to do. As you look down the list, I'll just highlight three things that are in the highlights section, starting with the bullet point. Starts with patient services revenue was over budget by 444,000 for the month of June, and over 1.5 million for the fiscal year. So the majority of that patient services revenue or variance from insurance revenue. So another good achievement there. Contracts and grants. So, and I guess the three highlights that I'm making are the three major contributors to the overall positive variance for the organization for the fiscal year. The second item here is the contract and grants revenue was over budget by 300,000 for the month and 1.9 for the fiscal year. And that's, like as Shanna reports here, largely due to COVID funding.
And Spencer, there's an error in there. It says 986 million. It should be 1,000. Oh, good. The very good.
Okay.
Or the remaining balance of COVID is in those.
The fourth bullet. Oh, right at the top. Yes, yes, definitely not 989 million. It's not, yes.
We wish.
We wish. Yeah, would be lots of different conversations. Thanks for pointing out. And then I think this is corresponds with the earlier conversation about staffing levels, but wage and benefit expense was under budget by 20,000 and 0.6 million for the fiscal year. So clearly understaffed or understaffed. So with that, let's flip down to the next document in the package, and that is financial statement highlights. And I don't think that in the history of RiverStone, we've provided this level of granularity. Maybe some of you guys that have been on the board for a long time can speak to that, but this is, I think, a first-time document that the finance committee saw, but it's gives you kind of the granular understanding of how the organization is performing in each of the individual service areas. So a very good document. I don't think it's something that we're planning on providing every meeting, but appropriate for this fiscal year and appropriate given the significant positive variance that we've had over the course of the last fiscal year, kind of outline that to some degree. So I appreciate Tyler and Shanna for putting this together. This is a great document. But you can see as it goes through that at the very top, we've already talked a little bit about the net cash on hand with the increase of 41 days. And then it goes into the key drivers of each of the individual areas where we've seen whether we've seen positive variance or negative variance. We talked briefly already about contracting grants, wages and benefits. Then on the second page, you'll get to see the impact of the pharmacy that we have, whether it relates to 340B or retail pharmacy, how that's continues to be a significant contributor to the overall revenue sources for the organization. So I won't go to those each individual areas, but I think it's a great document. It's worthy of review. And so I just wanted to make sure that I pointed that out. And then the third page goes into each of I think the one area where we've seen some negative variance is the home health area, and that's largely been by a lower volume, its inability to staff appropriately, as well as a smaller than expected reimbursement per day. So, but overall, the organization, from a financial perspective, very, very well over the last fiscal year. So that's a great testament to our management team and their efforts. If we skip all the way, let's see if I can scroll all the way down. But as we look at starting on page 32, if you're following along electronically, we get into the June 2025 financial statements. I think the balance sheet largely reflects what we've been talking about, any significant changes in that respect. So let's look at statement of revenue and expenditure. Net revenue for the month was $1.1 million. And our overall revenue for the year was close to $5.8 million. So that was a positive variance of almost, $5.8 million. So that is in part due to just our great performance, also in part to just the way we budgeted so that we could create some cash, because we're dig ourselves out of the hole that we found ourselves in the last fiscal year. That's that continued conversation on cash flow is all in the cash flow statement. We need to get into any great details there, but I think the bigger message is that probably unsustainable over the next few years, given the uncertainty around some of the federal grant contracts and that conversation, as well as the organization has operated about as lean as you possibly could, and likely unsustainable. So, but we do appreciate, I think, finance committee, everyone's efforts to kind of dig in and get the job done. And I think the forecast for 2026, which we didn't go into great detail here, does provide for some additional help and resources. what I have. Jen, anything you feel like?
No, maybe I'll point out the PERS adjustments. We always get to this point of the year and we have to book our proportionate liability as it relates to the retirement system. And it usually ends up being pretty significant to us organizationally. It's a non-cash expense, but we have to share in our portion of that liability. So they have actuary reports and we take our portion and add it into our financials at the end of the fiscal year. And so like last year, for context, it ended up being about a $1.3 million expense, non-cash expense, but something that we have to book. And so usually we get to the end of the fiscal year and book this and it really flips us upside down. Well, as luck would have it, this year, the impact was $79,000. I've never seen that kind of impact. So I'm just pointing that out because it, like I said, it's usually very significant. And this last year, or this fiscal year 25 didn't end up being too much. So we'll continue to.
I'm just curious.
Well, it's such a weird stuff. And so they determine how sensitive it is to changes in the discount rate. And it's just, I mean, our liability is like $22 million on our balance sheet related to it. And so if it's overly sensitive, obviously we would book a huge adjustment for it. And so it's such a weird one. And honestly, there's been quite a few years in the past where we get a revised amount. And so we always continue to watch the state site just to make sure that nothing comes up in the next month or two as we are working through our audit and to make a change in that. But just for context, like I said, it's usually very significant, and this year wasn't overly significant.
Right, budget for that, huh?
Yeah, I guess, but yeah, totally out of our control.
Other questions? Question, it looked like a lot of the asset acquisitions funded by COVID. So are we pretty much done? I should look at the balance sheet.
Yeah, we are. We have
So we basically used those funds that we had.
we
So
still have some remaining, and so we have some additional payments to make on the warehouse, the bus barn that will store that mobile unit. And then the mobile unit is actually leased over an 18-year term. And so there's some additional payments that will need to be made on that will come out of those funds. But as far as any staff time or any additional purchases of fixed assets, there won't be anything additional related to that.
okay, there are on my list. I have a variety of motions. The acceptance of the August 21st meeting notes.
So
Second moved by Mark, second by Lyle. All those in favor, say aye. Aye. We'll go the other way. Acceptance of the May 2025 financial statement. So moved, and I'll do Spencer as the second. Yes. Okay. All those in favor, say aye. Aye. We've got the acceptance of the June 2025 financial statement. So moved. I got Coach and I've got Mark. All those in favor signify by saying aye. Aye. The acceptance of the YHP financial statement. So move.
I, a second.
And and then the last is acceptance of the 2025 combined RiverStone Health and YHP financial statements. I got Spencer and I got Michael. Got them all? All those in favor, say aye. Aye. Okay, perfect. Lionel, you're up.
So the Safety and Quality Committee did not meet last month, but did this month. And primary topic was data innovation, which really means an inventory pretty much of all of the various data systems that we have to help us run the organization. So we have the systems that go by the names of Azara, Power BI, JetHub, and ECW EDO. And each one of these systems provides a different look at data from population health to clinical to actually the operation of the organization. And I think what I came away from that meeting was that there's a ton of data, a ton of information. And the big challenge is how do you make sure that the people who best use that information know how to use it and access it and all that. And so there is a data governance group that has been put together that's in fact working on that very topic. So I think I could use a lot more words and a lot more time, but that's pretty much what I got from the meeting. So,
Good summary.
Scared so we're gonna have more acronyms we're gonna have to learn.
yeah, I do have one question though. I don't remember where I read this, and this has to do with the credentialing of Lee Slagsvold. This is a nurse practitioner, and I read somewhere that somehow the Board of Safety and Quality Committee is supposed to weigh in on those credentials that are not clinic-based. And I thought, I didn't know that we were supposed to do that. And maybe we're not, but I read that.
We bring, yes, so we bring those clinical physicians to, that are home health or hospice or not, not associated with clinic. Clinic board approves those.
Yes.
And then we'll bring the others to board safety.
Yeah, but I haven't ever seen.
So that's a good question.
So, not that we need to, but it says that we do that.
We should.
Yes.
We should.
Right.
Okay,
I'm okay with Megan and John doing them. That's what it said. Okay.
well, yeah, that's what it said in the consent agenda item.
Yep.
Okay. So the motion to accept, minutes
So
from second. So I got Coach on one, I got Mark on the second. All those in favor signify by saying aye.
Aye.
Okay. I guess before the staff leaves, is there any old business so that when we adjourn for and go into executive session that they don't have to come back? So is there any old business or new business on the list? Okay. See, go ahead.
But you have to approve the evaluation
Oh,
Right.
in regular session.
Right. No, I can come out of that and do that as part of it. So.
Okay.
So with that, we'll take, let's say a 5-minute break and be back here for the boards. We'll just be, there's the evaluation, which I think was mailed out to you early. So sort of go through the process that was used, where it is, open after discussion. So thank you very much for attending.
So